Hi, good afternoon, everyone. Welcome back. Again, we're going to have our CME session today on dog QT. And this time, we have our resident consultant general and laparoscopic surgeon. He is Dr. Vikneswaren Wera Singgam. And before today, our topic is actually something very common that we see in, I'm sure we see it very commonly in the clinical. And the title for today's talk is actually Paradigm Shift in Peptic Ulcer Disease Management. Before we start, let me introduce our speakers today. As I said, he's Dr. Vinesh. He's graduate with MBBS from Manipal, and he obtained his postgraduate degree master in general surgery in UKM. And thereafter, he was posted as general surgeon in Hospital Umum Sarawak, Kuching for 2.5 years, followed by 1 year in Hospital Teluk Intan. He's also trained in minimal access surgery, where he has formal training in India and UKM in 2016 and 2017. His area of expertise are minimal access surgery, and he also has special interest in hepatobiliary and oncology tumor-related cases. And he is our resident consultant general surgeon since 2019. Without much ado, the floor is yours, Doctor.
Thank you for the kind introduction, Louis. So, okay, we shall not waste time. So my topic is actually a very common topic, which is peptic ulcer disease management. Okay, so as you all know, peptic ulcer disease is very common, and I will speak something very broad, and part of the topic is peptic ulcer. Dyspepsia is defined as having one or more symptoms of epigastric burning, sensation, postprandial fullness, or early satiation. This is actually the symptoms that comes under a big grouping as one of peptic ulcer disease. So bloating and nausea often coexist with dyspepsia, but are non-specific and excluded from the diagnosis. And then heartburn is excluded because it's primarily arising from esophagus. So when you have a big heading of dyspepsia, one of the diagnoses you have to think about is peptic ulcer disease. So I give you a case presentation of a 50-year-old man presented to my clinic complaining of epigastric pain for 2 weeks on and off. Described the patient's pain in burning nature, non-radiating, or worsens after it. I think commonly we will see this kind of patients. He has frequent belching, bloating sensation, but no history of any nausea, vomiting, diarrhea, constipation, and altered bowel habits whatsoever. So what happened? He consumed syrup Gaviscon, tablet ranitidine, which he bought from the pharmacy, but no improvement of symptoms. So he is seeking for help. When you look at the past medical history, he's hypertensive on amlodipine, dyslipidemia, and simvastatin, history of recurrent gout, on NSAID, Celebrex, and ibuprofen, on and off, but regularly. No significant past surgical history. Social history-wise, married, works at a private IT firm, drinks about 2 to 4 cups of coffee per day, consumes about 18 to 20 units of alcohol per week, which is significantly high. Chronic smoker, smokes about 20 cigarette packs per day for 20 over years. On examination-wise, nothing really remarkable, where the blood pressures are normal, patient clinically well, abdomen soft, lungs are clear, and cardiovascular systems are normal, per rectal examination is normal, so nothing significant. So in further history taking, we mentioned he had 2 similar episodes 6 months ago and a year ago. So what our patient did is he went to local GP, given some medication, and upon taking those medications, he felt well. He felt relieved, but claimed symptoms resolved, no change in lifestyle, continued the same, no diet change. So still no definitive diagnosis at that time. So upon seeing him, so I've cleared it based on history. I noted that it could be peptic ulcer disease, gastritis, based on history taken examination. Did the basic blood workout, noted were normal. I did an ultrasound abdomen, of course, looking for any gallstones. Counsel for OGDS, patient refused. Patient refused because it is a invasive procedure. Alternatively, I did a urea blood test for the patient. So once you've done a urea blood test, so we started the patient on Clasit. Okay. classic HPBD, which consists of clarithromycin, 500 milligram BD, metronidazole, pantoprazole. The latest guideline tells you about 2 weeks. Sometimes you can give for 1 to 2 weeks. And then most, as I mentioned, followed by any PPI, OD dosing for a month. So then what you do, you repeat back the urea blood test up to 6 weeks, where they're still positive for the patient. So what is the objective when you come across this type of patient? So you have to know, review some common causes, review the differential diagnosis, review the evidence-based management strategy. What are the strategy? What is best treated? Because there's different strategies. What to treat, and when to refer safely, effectively, especially in the primary health center care. That means we are talking about emergency ED in the clinics, okay, where your primary care, where you commonly see this kind of patients, when you're going to refer. So it's a constellation of upper GI complaint: belching, postprandial fullness, pain, early satiety, epigastric pain, epigastric burning in nature. So peptic ulcer disease comes under, as I say, it's a functional dyspepsia, where you diagnose with an organic etiology for the symptoms. So based on this, is defined by Rome criteria and subclassified into postprandial distress syndrome and epigastric pain syndrome. So functional dyspepsia, approximately about 38% are classified into postprandial distress, 27% are epigastric pain syndrome, and 35% meet the criteria for both. It's a substantial healthcare cost, not only for the patient, also for the doctors and also hospital managing patients. So as I said, when you have dyspepsia, we come under peptic ulcer disease, which is one of the common causes. When you ruled out all these, peptic ulcer, GERD, acute gastritis, then you diagnose the patient as functional dyspepsia. Of course, there's other causes: malignancy, gastric cancer, esophageal cancer, then other causes like irritable bowel syndrome, other GIT disorders, systemic disorders, renal failure, thyroid disease, and all this drug-induced dyspepsia, or which dyspepsia long-term never treat leads to peptic ulcer disease. So functional dyspepsia typically range 20 to 40%. The disorder accounts 3 to 5% of primary care visit. Most of the patients, 70%, have negative endoscopic study. 50 to 60% are classified as functional dyspepsia. So when we estimate the prevalence of functional dyspepsia, is challenging due to variable diagnostic criteria. They have overlap in symptoms with disorders and inconsistent. One thing most, functional dyspepsia, peptic ulcer disease, GERD, all risk factors are quite similar. Risk factors: females, increasing age, H. pylori infection, which I'll talk a lot about, concomitant with in thirds to peptic ulcer disease. High socioeconomic status, very, very interesting, not low. Smoking, non-steroidal anti-inflammatory drugs. And it's a very good chart to explain. When you have functional dyspepsia, you have EPS, epigastric pain syndrome. Then you have PDS, postprandial symptom. Then you have, these are the Rome 4 criteria. When they combine each other, if you don't find anything in between the criteria, it falls into functional dyspepsia as a whole. Then if you find something, an organic pathology, like an ulcer, like a GERD, they come under here. Then you have the totally ruled out everything, there's uninvestigated dyspepsia. So in epigastric pain syndrome, pain more than 3 days per week, or burning in nature 3 days per week, one of it. And of course, either one of these impacts life, that means their quality of life. No organic pathology, criteria is more than 3 months, symptoms more than 3 months, either one. And again, postprandial distress, again, it talks about postprandial fullness or belching more than 1 day per week, early satiety more than 1 day per week. And again, impacts on life, no organic pathology, so it takes 1 on 1. So again, these are the causes. I don't think so. I mean, these are the reasons why they actually modulate. You do not need to go much detail into that. Make it very simple. It's based on the European gastroenterology. You have diagnostic based on endoscopy, establish the firm diagnosis. Symptoms-wise, similar like peptic ulcer disease, then you treat them on different types of proton pump inhibitor. This, again, the Rome 4 criteria, but I already explained earlier. It's a similar charting. Again, you have the PDS, then they overlap about 35%. It's basically 1/3, 1/3, 1/3. 38, 35, 27%. Then you have a smaller group of uninvestigated dyspepsia. Treatment algorithm, make it very basic. Okay, when you have H. pylori testing, which I'll explain later, different methods. When it's positive, you treat and assess back the response. Negative, okay, now what do you do? You can consider a month of proton pump inhibitors. Proton pump inhibitors, there are different types. Everything has its own half-life and all that. You can go for Nexium, or omeprazole, or pantoprazole, or rabiprazole. If it's poor response, consider herbal. This is all very patients who have repeatedly, you give them on PPI, no improvement, then there is small roles of herbal, neuromodulator, psychotherapy, herbal. This is the last course of management, which I'll explain later. GERD. GERD is another group of symptoms or presence of mucosal damage caused by abnormal reflux of highly acidic gastric content in the esophagus or beyond, including into the oral cavity, respiratory pathways. Because of the high acidity content, it refluxes up into the esophagus and causes ulceration. The patient can present with esophagitis, can lead to Barrett's esophagus, and also predominantly can lead to peptic ulcer disease. So 10 to 20% patient in the Western world see one of it in the US, where the overall spending is about 20 billion yearly. Symptoms of GERD, I think you all should know. Classically, heartburn, they regurge. Patients will typically, what they'll explain is very bitterness in their mouth, they can't feel taste. Then they have the atypical symptoms where chronic cough, asthma, they can present with nausea, laryngitis, coughing. They can present with chest pain, mimicking like having an MI. So these are the classical of the normal symptoms of GERD. You have to remember about the alarm symptoms. They can be potentially associated with life-threatening condition, which I explained: stricture, malignancy, chest pain, myocardial infarction. Untreated GERD, I explained, may lead to serious complication: peptic strictures, Barrett's esophagus, reflux esophagitis, malignancy. Brief, I will explain on GERD, where the sphincters became loose because of various reasons, as I mentioned, all the risk factors. So high acidity content from the stomach, they refluxes up and causes ulceration. So it's healthy person, that's a GERD. So diagnosis is the same based on history, clinical examination, and upper endoscopy. You can visualize tissue biopsy, then you can demonstrate mucosal damage. So most patients of GERD do not present with abnormal OGDS, but they have abnormal hiatus hernia or hernial presentation. So reserved for evaluation of GERD complication or placement of pH probes. So you can do that. Your upper barium swallow studies, it's a bit outdated, low sensitivity and specificity, but you still can do, but not commonly done. Then this is what they call it, ambulatory 24-speech pH monitoring, where they'll place a probe inside your stomach, then it's connected to here, and it will do the reading, where it will tell you the high acidity in the stomach. Very important, because it will quantify a reflux of frequency and information between the timing of each actual reflux. So that's why they do this study for 24 hours. Why they do this? The GERD is those who don't respond to PPI. So there's a small group of patients who don't respond to PPI, and you keep giving them PPI, there's no improvement of symptoms. So these tests, they also demonstrate 5 to 15% reflux corresponds to the patient symptoms. So Hill classification on GERD, this is grade 1. You see a prominent, this is between actually the junction between the stomach and the esophagus, and you're looking inside the gap. So when you look at the gap here, grade 1, this is between the scope, stomach, and what it sees through is the esophagus. So it's looking reverse, So you don't see much of that, but little bit of the fold. See the color change between the esophagus and stomach? When you look at the grade 2, you see a small gap here. This is actually the esophagus tissue. This is the stomach tissue. This is the part of the fundus. And grade 3, see, widening a bit more. This tissue is actually the esophagus tissue, and you're looking reverse again, I'm telling you. And this is huge, you see. This one actually you can put through the scope also, very big. So this is basically called grade 4, or in some, we call it as hiatus hernia. So 24 hours pH monitoring, urea blood test, role of endoscopy, important if you ask me. How you manage the patient's dietary advice, lifestyle modification, and you can offer patients a full dose of PPI, 4 to 8 weeks. But for me, this is very important. Dietary advice and lifestyle modification, I personally feel that's about 70% of how a patient gets well. No point just taking the medicine and there is no improvement if they do not do anything to improve their lifestyle. So symptoms recur, you can offer them at the PPI lowest dose to control symptoms. H2RA antagonist like your ranitidine if there is inadequate response. And then the role of H. pylori, which I'll discuss later, key. Surgical management, put it very simple, they do with lap fundoplication. Basically, once you confirm there's reflux, so you want to prevent, and those who are indicated is those who have severe acid reflux, not tolerating to PPI, and can't tolerate the acid suppression therapy, and recurrent admission due to severe gut, poor quality of life. So base very simple. So as I mentioned in the gap, so this is normal stomach. They'll wrap the part of the stomach around the esophagus to make it tighter. So this is an anterior wrap, a Nissen fundoplication. This is the posterior wrap, door fundoplication. Then this is called as a 2-7 two-pay fundoplication. So each fundoplication has its own advantage, disadvantage, but I'm not going so detailed into the anti-reflux surgery. I just want to show you all, this is grade 4, typically the hernial sac. This is what happens when the part of the stomach bulges. This is the thoracic cavity, and this is pre-surgery. When you look at it, this is all features of esophagitis. Post-surgery, 6 months later, you see it's very clean, very smooth after the wrap. The basic is you want to fix the sphincter, you want to tighten the gap between the crust so that you want to prevent, or in other words, to reduce the reflux into the esophagus cavity. So peptic ulcer disease, as I mentioned, all these are spectrum of disease. They are hand in hand together. That's why I explained as a group. So in classification is discontinuation inner lining of the GI tract because of gastric acid secretion or pepsin. All the management is quite similar. So common cause is H. pylori associated or NSAID majority. I will speak about H. pylori, a major cause for peptic ulceration. Lifetime risk development is range from 5 to 10%, but I can see ideally it can be in a higher level also. There's decrease in incidence of PUD worldwide due to improved hygienic and sanitary. So because there is much treatment down the line, so people are aware to reduce or effective treatment of judicious use of NSAIDs. There's still people use NSAID, but then they still cover with PPIs. So renal ulcers are 4 times more common than gastric ulcers. This one more common than that. So all these etiological risk factors, actually peptic ulcer disease, so much of risk factors, H. pylori, NSAIDs, medications, steroids, bisphonates, smoking, excessive alcohol consumption. Why I put excessive is anything you want to abuse is very bad. Zollinger-Ellison, malignancies, transviral infection, vascular insufficiency, radiation therapy, Crohn's, and chemotherapy. So this anything that is in excessive. So these are all rough risk factors, and etiology, you have to ask the patient whether they are included in that. So typically, as I said, like dyspepsia, like your GERD, they're similar. Common epigastric pain, bloating, abdominal fullness, nausea, vomiting, weight loss, weight gain, hematemesis, melena. Then you have said that the warning sign I mentioned earlier, which need prompt referral. Okay, unintentional weight loss. That means you're losing weight loss. Typically, they say 10% of your body weight in 6 months. That means losing about 10%. 3 to 6 months. Progressive dysphagia, GI bleeding. Overt, meaning that when you do stool local blood, it's positive when you wear it. Of course, fresh blood, there's actively bleeding. Iron deficiency, anemia, recurrent MSS, and family history of upper GI or stomach malignancy. Very alarm symptoms. So A for anorexia, L for loss of weight, A for anemia, of course, iron deficiency anemia, R for recent onset of persistent symptoms like vomiting, M for melena. Then you have dysphagia, epigastric mass, and all right. This is the Forrest classification. Okay, the man who invented it was J. Forrest, 1974. This is rare and types of peptic ulcers. So 1A is an active bleed. 1A, 1B are active bleeding, acute hemorrhage. So the morbidity is higher, mortality also higher, and the rebleed risk class. So this is active spurter, spurter at the ulcer. 1B, actively oozing, it oozes little. These, when it comes to 2, recent hemorrhage, or recent bleed. 2A, you can see a visible vessel, no active bleeding. So a visible vessel. So you can put a clip. Ideally, we'll put a clip. Okay. This one, the methods are there. 2B, there's a clot here. Okay. So what will happen if you dislodge this clot? There might be an ulcer, might bleed again, might be a visible vessel. We're not sure. So if you dislodge, you will know. 2C is basically it's healed off. So it call it flat base. And then or hemosiderin base. Clean base. Clean base ulcers forestry. Okay, you see everything is clean, it's possibly healing. The risk of rebleed is lesser. So from 100%, 60 comes back down to 3 to 5%. So again, the investigation treatment are quite similar. Gold standard OGDS. Yes, why you want to know what type of ulcer? Is it bleeding? Is it cancerous? We need to know. Barium swallow is when OGDS is contraindicated. Yeah, so we have to remember OGDS is a safe procedure, still is an invasive procedure. So when it's not indicated, then you do barium swallow. Complete blood workout, liver function, levels of amylase, lipase, serum gastric, if you suspect of Zollinger-Ellison. Then all this H. pylori testing, which I will explain later, which is very important. Serologic testing, urea breath test, stool antigen, urine-based ELISA, endoscopic biopsy, and CT. CTY, limited value, you want to diagnose a PUD. But in terms of there's a perforation, peptic ulcer disease perforation, very important. You want to see, look at the free M. The patients with peptic ulcer disease, you want to rule out gallstones because they can come in and very helpful. Or an ultrasound abdomen. So H. pylori reduction therapy to people who have tested positive, who have tested positive for H. pylori and who have peptic ulcer disease. You can offer them the eradication therapy. For people who are using NSAIDs with diagnosed peptic ulcer, they stop the NSAID. It's very important. Example, those patients who are osteoarthritis, gout, they had loads of NSAID. So advise the patient, change the type of painkillers, and then offer them PPI or H2 receptor antagonist as cover. Give them about 4 to 8 weeks. If H. pylori present, you eradicate the patient. And then people peptic ulcer disease, H. pylori, retesting. Okay, very keen. If they are positive, once you are treated, the retesting is ideally 6 to 8 weeks after the initial treatment. In general management, manage like in primary care, advise the patient, look for alarm symptoms, signs, major determinant of the need for OGDS. So you can treat, not age on its own. Age, you can scope the patient at any age, but look at the alarm symptoms. Long-term care should emphasize patient empowerment with on-demand use of lowest efficacy dose of PPI. So as I said, this is weight reduction, diet control, increased physical activity, and smoking cessation, alcohol reduction, which is very important, 70%. So empirical treatment can be done. So I would like to speak a little bit on H. pylori, and then how you do the testing for it and how to look for whether it's still positive or not before I round up the eradication therapy. Common bacterial infection in humans affecting 90% of patients. Duodenal ulcer and 80% with gastric ulcer. This 90% is duodenal ulcer, 80% gastric ulcer. Root direct contact, infected person, either fecal oral, oral, or gastro-oral pus, discovered 1982. As I said, healthcare estimation budgets are unbelievable, close to $1 billion in 2015. Again, many misconceptions regarding proper diagnosis and treatment of infection still exist. So, very important chart. Diagnostic test before treatment of H. pylori. Before, so you got the invasive method, got the non-invasive method, and the invasive method. I make it very simple. Non-invasive means serology, blood taking. Invasive method, you got HPE, culture, polymerase chain reaction, and rapid urea test. Non-invasive method is the normal. Go to any blood lab, take blood, check for enzyme immunoassay, and detecting for the IgG. Sensitivity and specificity is 60 to 100%, not 60 to 100%. Relatively cheap, available. Results are quite fast. Drawback is the thing is existence of antibodies in the host even after eradication therapy. It means even after you treated the patient is well, can still be positive. And that's a problem. But it's good at correctly identifying patients with negative result, and it's good alternative to the urea breath test. So it's good. That means if it's negative, but positive means doesn't mean still positive, it can be negative. Then invasive method, OGDS, is what we'll do. We'll scope the patient. We'll take biopsy the patient, and then we send it to the lab. Usually we will do it in the rapid urea test, which I'll explain below. But this is one side because the sites usually not so technical in terms, but these are the sites based on the Sydney classification, but can be uncomfortable for patient and time-consuming procedure. Although it's 10 minutes by the time. Why I say time-consuming? You admit the patient. By the time it's like a daycare. And some are fear factor for that, for OGDS. Culture, obtain the gastric biopsy assessment, then you ideally culture for H. pylori. Again, less invasive than biopsy collection, include the gastric juice sampling. But I personally not come across any experience of this, but this is based on theory. Again, sensitivity is lower, biopsy specimen are used. This is good for knowledge and this is going on. Polymerase chain reaction or PCR. You can identify small traces in samples, a few bacteria present, can be performed faster. Drawback is can detect DNA segments of dead bacterium. So we don't want any dead bacterium which can be detected, can be a false positive. So you can throw off your result, and then you're going to end up treating the patient with empirical eradication therapy when the patient is supposed to be negative. This is what we do and I do commonly. Scope the patient, we do a rapid urea test. That means we take the specimen, random biopsy of the stomach, especially the antrum and the areas I mentioned. You can go for lesser curvature, proximal angulus, and greater curvature. This is ideal 5 biopsy sites. I preferably go at the antrum, take 5 specimens, and then we test for RUT. So obtain endoscopy place in a medium containing urine pH. What happens is breakdown. So it decreases the urethra, which could be caused by it. The color will change. So the color will be usually yellow as negative. It turns into pink. Can be mild pink, bright pink. Sometimes when you put it in the medium, it can be negative. But next day, if you reassess again, so as I said, 24 hours, it will be positive. False negative results will either due to decreased urease activity, because these are talking about the breakdown of the urease, or recent intake of antibiotics, bismuth compounds, or proton pump lower inhibitors. So as I mentioned, very simple, serology, non-invasive and invasive methods. So test to detect the eradication infection. That means once you have already eradicated the patient, 6 weeks later, you want to test them. Have you eradicated? Then common test is urea breath test. The ability of the H. pylori in present gastric environment break down the absorbed carbon or carbon-14 label into CO2 ammonia. So you basically ask the patient after 6 weeks, blow into a bag, and then you check the reading. So can be safely used in children or women of childbearing, generally used to measure the C13 in breath samples. Beauty about this is the sensitivity and specificity of the UBT exceeds 90% most of the time. Post-eradication therapy is very important because it is non-invasive and such easy to be done. Stool, there is role, but again, I rarely come across. Can send them to see the presence of antigens against H. pylori. You don't stool. That means you can send it to the lab. You don't need to come to the hospital. Collect the stool. It's a reliable method to diagnose an active infection, confirm effective treatment of infection. Stool salts, you can sample, store them for about 24 hours room temperature or 72 hours at 4 degrees. Only problem is without refrigeration, the sensitivity drops within 2 to 3 days. Untreated patients, when we detect H. pylori, it's comparable to UBD, but in ideal, optimum conditions. Post-eradication in populations with low H. pylori prevalence, the performance UBT is superior. So this is based on few studies. Eradication therapy, okay, for those who have peptic ulcer disease, GERD or functional, you can offer them 7 to 14 days, twice daily. This is based on the NICE guidelines. I'm taking from the NICE guidelines from the UK. Twice daily, and then combination of a PPI, amoxicillin, or either Claritro or metronidazole. If they're allergic to penicillin, you can maintain the same combination. You can change to metronidazole. Very simple. PPI, amoxicillin, clarithromycin, as I mentioned. If they're allergic to penicillin, then you change to metronidazole. If they're allergic to penicillin and previous exposure to clarithromycin, it's something combination of a third therapy, they call it, for PPI, bismuth, metronidazole, tetracycline. Okay. Second line treatment is when the first line have failed and then you've treated the patient comes back, symptoms no improvement. Now, what do? You can give them a daily course of the same thing, but if you have given them clarithromycin last time, you can change to metronidazole, whichever you have not used the first time. So that becomes a second line for the patient. Quite simple, right? So those who have seen you have had previous exposure, that means you have given them Claritro or metronidazole, still not working, then you can put them on a PPI, amoxicillin, then you change the third one to tetracycline or levofloxacin. So it's just the change of antibiotics. What becomes constant is your PPI and your amoxicillin. What happens, those who are allergic to penicillin and who had not had previous exposure to fluoroquinolone antibiotics, then you can put them on a PPI, metronidazole, levofloxacin. All these, you can look at the UK guidelines. As I say, they change. And then those who are allergic to penicillin, who had previous exposure to fluoroquinolones, you can use the PPI, bismuth, metronidazole, or tetracycline. So these combinations, actually, you can look up into the guidelines. It's much easier. So active H. pylori infection, if they are penicillin allergy, you can put them on PPI, clarithromycin combination, or they call it the bismuth quadruple therapy. If they are sensitive allergy to clarithromycin, then you can put them on 2 weeks of this, clarithromycin, PPI, amoxicillin. Resistant, then you can follow the chart here. These charts, this first line, second line, you can look at the CPG guideline, you can follow the NICE guideline, you can follow the American guidelines. Yeah. What about eradication therapy in pregnancy? Generally, when I'm referred a patient with peptic ulcer disease, we try not to do a scope unless patient has hematemesis. Then we look for any tears at the junction. So most of the time, ulceration is very rare, but they can have actually tears. We can treat them with PPI, which is safe, and then eradication should be completed after childbirth. Ideally, we try to avoid, because some of the medication, as I said, the bismuth quadruple, quinolone, tetracycline, are contraindicated in pregnancy. Measures should be avoided. So we try to avoid antibiotics at the least. This chart just a basic. I think you all should know. But you can follow these guidelines. The dosing: 20 milligram, 30, 20 a day. Of course, the standard dosing is 40 milligram, but that is based on the low dose or high dose. And then there is also what we call as infusion. Infusion, they say peptic ulcer disease, there's active bleeding, you can give 80 milligram. That means now it's 40, right? You can give 80 milligram, then we give 8 milligram per hour infusion. That's for active bleeding. We can give for 24 to 48 hours when there is active bleeding, pre and post scope. This is just the dosing, updated. So when do we, or when you want to refer? So when is it? Immediately? Or if highly suggestive of cardiac or biliary disease. So you have to make sure you have ruled out whether it's cardiac in nature or biliary disease in nature. Cancer suspicious or proven. Unsure of the diagnostic, uncertainty. Treatment's not available. That means what is the least you can treat? Failure of medical treatment, symptoms are persistent despite you have counseled them, despite you advise them, and despite many medication. Or sometimes when they come to your clinic, or sometimes to the ED, they get a specialist opinion or second opinion, then that's good. I will skip this one. It's not so important on the flow chart. So I mentioned earlier, dyspepsia, after you rule out, these are the other role of medication modalities. Role of antidepressants, prokinetic agents, psychological treatments and behavioral therapy, relaxation therapy, psychodynamic psychotherapy, and cognitive therapy. This one, personally, in my own experience, I've seen so much of patients who keep coming back despite in your eyes, everything is normal. The blood test, ultrasound is normal. The scope is significantly not remarkable. I seriously feel sometimes these are the roles to play, because they feel something is not right in their body. They're still complaining pain, and you keep changing. I think these are fairly many underdiagnosed this type of patients. A lot of foreigners, I don't know, for some reason, it can be related to some psychological treatment or behavioral therapy will be beneficial for these patients. But again, this is from my personal experience, nothing from any data, anything. So what are the take-home messages for your listening? Very simple. Always look at the aggravating factors: tobacco, NSAIDs, alcohol consumption, sedentary lifestyle. I think history taking is very significant and important when you want to manage a patient, because they keep telling you what you want to listen, but sometimes they don't tell you. Alarm symptoms and signs, whether present or absent. When the features are absent, so you can, in the first line, you can try them for H. pylori infection. You test them, they're positive, put them on empirical treatment. Or if they're negative for weak cause of histamine 2 receptor PPI. This is when it's alarm symptoms absent. Failure to respond to treatment justifies further investigation or referral. When the alarm symptoms present, then you do a OGDS, do a biopsy, you refer them to do the CT scan, and then you further investigate the patient. A referral is very important. Fairly functional dyspepsia as part of peptic ulcer disease is a clinical challenging diagnosis. People think it's very simple, but because of the spectrum in upper GI complaints, they overlap in symptoms with other diagnoses. So they have a poorly defined pathophysiology. That means when you already diagnose peptic ulcer disease, it's straightforward. A GERD is straightforward. When you find everything's normal, patient's still complaining of gastritis, pain, they become a functional dyspepsia. So it's very hard to manage. So you have the spectrums are becoming very difficult. Many guidelines, many management to manage the patient. So in a common condition, health community, burden to health service, and treatment should be started in primary care setting. It's nothing wrong actually to start treatment, trial of medication first. If all that fails, but prompt referral is important when you're looking at alarm signs, when you've tried many medical treatment that fail, or you keep seeing the patient back to your setting despite advice, medication, no improvement. I mean, you feel something needed to be done to improve the patient's quality of life and also their symptoms. Okay, thank you.
Hey, hi. Thank you very much, Doctor, for your very solid and comprehensive talk. And we have several questions from the doctors here. First question, what is the appropriate lifestyle modification or diet for a patient with GERD? I mean, what you normally advise the patient?
Actually, it all tailor-made for the patient. Okay, so when you talk about lifestyle, you have to get the history of the patient. So you have a patient, for example, like if he's smoking or alcohol consumption, then you have to ask them to stop doing that because they're aggravating factors. Yeah. If you have a patient who have their diet-wise, they're taking a lot of spicy food daily. Spicy food means not just once a while is okay, but one thing. Every intake is too much of spice. Then they take a lot of coffee, caffeine based, one day 2 to 3 coffee. So you know already that they skip their meal. Okay, they don't take their breakfast. Lunch maybe they take late in the evening. Dinner they take out of timing. Then they take dinner, they go and sleep immediately. This lifestyle. So what is ideal is take your meals on time. That means breakfast, lunch, dinner. Ideally, you take food, dinner 4 hours before you sleep. Why? Because your gastric emptying, you want to digest your food, takes 4 hours. When you eat immediately 1 hour before you sleep, your food is still in your stomach. So it's not digested yet to go down. So you next day morning, some people they'll have reflux, they'll vomit out, they'll curb. Some people they sleep at about morning. Say for example, you sleep at 2 o'clock, you makan at 1 o'clock. You wake up 7 o'clock, your food is still in the stomach. So you will vomit out and regurge back. That causes ulceration in your esophagus. So this is what I call about lifestyle modification. You see, you don't. Some people they work in the night because they may be your operator or guard and all that. No, their timing line is totally different. So they are not the same for everybody. So diet wise, okay. When I say coffee, you can't drink. No, you can drink coffee once a day, but not like you take 4 coffees a day. Even food, certain types, you talk about all the citrus based like lime, lemon, all this fermented food. You can have it once a while, but not like every meal you have fermented acidic food. Every meal you have orange or even lime, lemon, because all that is acidic. Gas drinks. So it all a balanced moderation when you counsel the patient. Some people they like to drink too much of gassy drink, Coke, every meal Coke or 100 plus or root beer. So that's what I say is your diet and behavior is all must be balanced lah.
Yeah. Okay, that's I got it. I think that answered the question. I think they're subjected to patients' existing lifestyle. Then from there you advise accordingly. The second question, for H. pylori IgG, if positive and never been treated, can the doctor start eradication therapy?
Yeah, I mean, there's nothing wrong. If it's positive, even positive and patient have some symptoms, you can eradicate them. So, okay, the guideline now tells you 2 weeks, but I personally, I will still give, last time it's 1 week, then they change it to 2 weeks. I still give 1 week first because some of the antibiotics, they have side effect. So some they cannot tolerate. After 1-2 days, they'll have nausea, vomiting, then they have tiredness, all different spectrum on different patients. So you give 1 week first. I think 1 week is sufficient, positive. Then after 1 week, you review them back, they are okay. Then you put them on PPI. That means either your Nexium or pantoprazole, one dose OD for 1 month. The whole treatment is actually about 5 to 6 weeks. Then it's okay. You can start them on eradication therapy.
Okay. Third question. Is eradication therapy for children? What is your comment?
Okay, it's a very, very good question. Okay. So I see a lot of patients who in the teen ages, they come for all this gastric. Okay. Their lifestyle, you look at it, they sleep late, they play video game, they get stressed, they can get H. pylori. I try not to scope when they're very young. Why is because it's an invasive procedure and I don't have the bad experience. So I'll do what they call as the urea breath test. Or I can do the blood test. If it's positive, I'll put them on eradication. So few of them actually act very well. There's nothing wrong to start on children. Because doing an OGTS, I feel, is invasive. And most time, when you find the risk factors, it's actually they're doing something wrong. They will eat lunch or skip lunch on the late dinner late, and then they'll eat some fast food, not enough rest, not enough sleep. Either can be exam stress, they can get. So these are the groups you can start them on H. pylori. But as I said, do the ELISA test or do the urea breath test. If say eradication is not working and all that, then you can do a last treatment as OGTS. But most of the time they have responded very well.
Okay. The subsequent question: what is the duration for prescribing PPI?
Okay, so you can give about 4 to 8 weeks. So in an ideal setting, I would give for 4 weeks. You can give OD dosing. Don't give BD. BD only for a short-term period only. That means 1 week to 2 weeks you can give only during eradication therapy. Then you can give OD dosing. Give for 4 weeks. Then after that, see back the patient. No improvement, you can put them another 4 weeks. Yeah. But as I said, it's subjective to patient. And again, you don't want the patient to be long-term reliant on PPI. But some patients, a certain small group will be in long term, especially those who are on blood thinners like cardiplin and all that. They will be in the long term,
Mm. Okay. Now we have some questions from our resident MOs. Are there any chance for peptic ulcers to recover by itself by diet and lifestyle control without taking any medication?
Okay. Peptic ulcer bites. Okay, it's a very, very good question. It's very, very okay lah. By itself means by itself. Okay, first thing we always advise the patient is lifestyle modification and also, as I said, diet and all that. Technically speaking, if the patient has no symptoms and feels well, I assume the peptic ulcer is healed already. If no means, that means they're coming back. So technically speaking, as 70% is actually in the patient's hand. Lifestyle, everything. But again, 60%, then another 30 to 40%, whatever you do also cannot because they've got certain medication. So for me, can but if they have already peptic ulcer, see you do a scope, no, you still need to put them on medication. That means technically, if I do a scope, I find an ulcer, I will definitely, it won't heal by itself. You need a medicine.
I see. Okay, what is the type of food? Second question from our MOs. What type of food that recommended for peptic ulcer disease patients?
Oh, that is all in your risk factors just now I mentioned. You cut down on your coffee, your tea, all caffeine based, citrus food like lime, lemon, all the fermented food, spicy food. Okay, and then you also want to cut down those food with very high acid content, gassy drinks. All these have some form of toxic that causes acid imbalance in the stomach. When acid imbalance in your stomach, that leads to peptic ulcer disease. So I would put the question, what are the type of food you won't recommend for peptic ulcer disease? The rest of it is recommended, like the fish, chicken, all that. So I can put it the other way.
Yeah, because usually when people have gastric or GERD, and I mean this is like traditional. People will advise you drink milk. So you drink milk, you feel better. What is your opinion about that?
Actually, some people say cannot drink milk. There's two things, But this milk, actually, this is all I feel is just meat for me. I mean, to be honest, it's something like I don't know It's like, for example, if you ask the Chinese after surgery, right? You can't take egg. I don't know why you can't take egg, but we as surgeons, we believe egg as high protein. So we can't explain that. So actually, there's no such thing that milk thing.
This is a belief. Okay, third question. Can peptic ulcer lead to cancer?
Yes, definitely. Okay, long-term peptic ulcer lead to cancer. So when we found an ulcer, right, and I scope already, ideally you need to rescope the patient in ideal circumstances but of course we effect of costing and all that. 6 weeks later we scope again. If the ulcer is still there, you treat again with eradication and PPI, then you scope again after 6 weeks. If the ulcer is still there, there is after 3 months, if I'm not mistaken, if the ulcer is still there, it's called it recalcitrant ulcer. So that ulcer very high risk of developing gastric cancer. So you can subject the patient for part of the stomach to be removed for recalcitrant ulcer. So ulcer, if not treated, definitely long-term risk for gastric cancer.
Okay, the fourth question. Can the patient still consume alcohol once diagnosed? Is it necessary to totally abstain?
Ideally, I mean, who's going to tell you to take the alcohol? I mean, you already say you got a peptic ulcer. Why you okay, of course need to stop drinking. I mean, there's no one going to tell you continue drinking alcohol after your peptic ulcer, right? It's only going to get worse.
Yeah. So I think as a consultant, of course, there's no gray zone, it's just a black or white.
Yeah, I mean, of course, patients won't listen sometimes, so we can't do much about it. But ideally, in medical terms, you ask them to stop. But again, how many people are going to stop, So we just leave it to the patient. Sometimes you just tell them, like, you have to cut it down. That is the ideal fact because they're not going to listen. So we just tell them, ideally, in an ideal world, perfect world, you have to stop.
No lah, some patients are still very obedient. Okay.
Yeah.
Okay. A subsequent question. May I ask about the role of probiotic on peptic ulcer disease?
Okay, the role of probiotics, there's many pros and cons, but then again, you can use that, but not for a long term. Because when you use probiotics, I use probiotics mainly those for patients in my those who undergo colonoscopy, and then they have flatulence or colitis and all that. But I give them about 3 to 4 weeks only. That's it, done. I don't put them on a long term because any antibiotics in a long term, you can, as I said, you can give them, but not in a long term because the commensal bacteria can cause a resistance. And then next time, if you have an infection, then you treat the antibiotic, it's not going to work on the patient because they are already the flaws of the microbacteria becomes resistant. So anything short, I think no issues, but anything you want to take long term like a supplement, better not.
Okay, I have a question. Is that do you recommend the clinics to actually carry out any form of test to check H. pylori when the first time seeing the patient with all these related symptoms?
Yeah, I mean, I think the most simple is the blood test, the ELISA immunoassay. Just like blood taking, you can do that. You can do the test because if you want to do the urea blood test, you still can send, but they don't have in PET lab. You can do the H. pylori test. That one you can do that. So I would recommend that. If you go into the stool antigen test, I'm not sure whether the PET lab do. I think they should do. You can send the stool. But I rarely come across people send stool. And then the urea blood test also sometimes too technical. That one is you come to a specialist center, then we will do when recommended. But ELISA the blood test is good. Then if you think it's positive, start on treatment. If it's negative, you can put them on PPI and then test back again after 6 weeks. But I recommend on the clinic side to start on ELISA. That's very cheap, easily available, and can start treatment early.
Do you see more and more cases, pertaining to this disease, in your clinic's practice? Nowadays?
Very common, Sean. Very common. If you go emergency, very common. I'm very sure in the clinic setting, very common. My clinic, very common. But of course, our center, you come with pain, abdominal pain, gastritis, very, very common. So very common, and sometimes, that's why I said, my medical officers, they can treat. If they're not working or not improving based on the symptoms, then refer back. And then if the clinic, they try to improve. But always catch on patients who keep coming back the same symptoms. Then you don't want to treat. They come 2 to 3 times and then you give medication. Then you must bear in mind, this one must refer. Why is it coming back? Something is not right. So the first time, second time, or first time, better can start treatment. But answering the question is very, very common.
Okay, I think there's no more other question. Okay, there's no more questions. So, okay, I think we can wrap it up the sessions. Doctor, any key message or take-home message for the GPs, a medical officer out there? Yeah.
I think the key message is if you find a peptic ulcer disease, you can follow the guidelines I mentioned earlier. If they are positive, put them on eradication. Not positive, you can put them on PPI, advise lifestyle modification, diet control. Then you try to manage. If you feel the patient is coming repeated, better refer. If you find some alarm symptoms or very suspicious, refer. If you feel that the patient is not improving after you've started treatment, better refer. So it's not. Sometimes you can manage these patients by yourself, and then if you feel that it's out of the patient is repeatedly not improving, then you can refer the patient earlier to anyone.
So thanks, doctor, for your talk again. All right, thank you, Doc Witty. So we hope to see you again near future. Thank you.
Thank you.